Nick, what's going on, man?
Hey, how's it going, man?
It's going great. It's going great. Thanks for rescheduling all everything that we had to. It's been
Of
like two
course.
months. We've been trying 3 months even,
Busy
right?
guys, that's it, right?
Yeah. How was your day? How's everything going?
Good, good, man. Good. Just working away.
Yeah.
How about you?
Good. It was a long day. It was a long day. A couple of different things. Actually, a lot of kids. I've been seeing a lot of kids, which you are a
Okay,
specialist in, right?
perfect.
So, yeah, maybe I could pick your brain a little bit
I'll,
through
I'll
the
try. I'll try, definitely.
chat here. Great. So you're in Toronto, right?
Yep. Just moved here about 5 years ago.
5 years. Okay.
Yep.
And you've been in
I
pediatrics?
was,
Oh, yeah.
yeah, so I was born and raised in Montreal, and then I did my dental school in Montreal and at McGill, and then did a pediatric residency in Rochester, New York. And
Oh, no
then
way.
back to Montreal, worked there for a bit, and then 5 years ago I moved to Toronto. So I've been in pediatrics for about 12 years now. Yeah.
Wow. Very nice. I visited Montreal. This is going back, I think, 9 years. It was in my gap year in between undergrad and dental school. It's about 9 years. And I really liked it. It was like a quick 3-4 day weekend kind of thing. It was, you guys, it was in, I think, June. So you guys had like is that where your Independence Day is?
We have like a Montreal, like it's a Quebec, it's a province day. Yeah.
Yeah, that
Yeah.
one. Yeah, it was
Yeah.
a really
Right
good
after
time.
the Formula One.
Yeah, that's right. Yeah, Montreal's a lot of fun. How are you like in Toronto?
Toronto's good. Big city. So busy. But honestly, I moved here for work. So like the mindset's a little different. When I go back to Montreal, it's kind of like cozy vacation mode and it's home. It's comfortable. Here, I'm kind of new and moved here in my 30s. So it's always a little bit more new stuff, different.
Right. Yeah, because Montreal had like big city areas and
Yeah.
also like little kind of Williamsburg, like Brooklyn, like and Rochester. So you were there for Rochester. That was 2 years.
2 years. Yeah.
2 years. Got it. Okay. And then back to
That was
Montreal.
different too. That was very different too, going from Montreal to Rochester, and I was like, oh, it's New York, it's going to be a big city. And when I got there to visit, I was like, oh, okay, this is smaller than Montreal.
Totally different, right?
Yeah, definitely.
And how'd you like Rochester?
Rochester was nice, honestly. Like I think it's hard because you go in with that mindset of residency, and you literally spend every day with your residents, and we're
Yeah.
still friends now. 12 years later, we're still friends. But I remember is the good times, and I'm like, oh, I loved Rochester, but maybe not for the city, but more for the people.
Yeah. The city, I did a basketball whatever camp thing there, and this is going back like 15 years. I thought it was like very gloomy.
Yeah, yeah, I can see that.
Yeah, yeah, it's
Yeah,
like really
there were summer days, but at the end of the day, it's still close to the north, so you
yeah,
get those cold days for sure.
yeah. I felt like it could have been a little more lively. It was dead smack in the middle of summer too when I went also, but no, Montreal was cool. I like Montreal. I've
Yeah,
never been to Toronto.
Montreal definitely is cozy. Have you been to Toronto before?
No, never been.
No. Okay. So, I mean, Toronto is definitely fun, lots to do. I think it's very vibrant and lots going on. Montreal has its own fun. It's definitely culture and food spots are good and nightlife is great and it's
Hmm.
safe. Both of them has pros and cons.
And how was dental school? You were probably mostly with residents in Rochester from the U.S. No,
Pardon me?
when you were in Rochester in residency, you were probably with mostly other residents from the U.S. or was it everyone?
Yeah, it was all US. I was the only Canadian in my year. And then I like previous years, Rochester is still pretty close to the border. So a lot of
Yeah,
Canadians go like from Toronto and Montreal. So I've had like my mentor she graduated from Rochester. So it was kind of, I was just following in her footsteps. And
yeah.
when I went there, they were familiar with the Canadian system. But when I was there, it was only me that was Canadian. Yeah. All my residents,
Yeah.
co-residents were American.
I'm curious. You want to go into the differences a little bit between like dentistry in the U.S. and then maybe I mean the number system's the same, right? Are you guys using international or are you using like
We use
the
the international. We use the international. Yeah. So it's different. Yeah. So it's definitely like the two biggest changes that I remember was one, the pronunciation of composite and composite. That was my biggest, everyone made fun of me because I pronounce it composite. Canadians pronounce it composite. And then when you go to the US, it's composite. And then you can really
I didn't
distinguish that.
realize
And
that.
then the numbering system was the other one that, they're all like, do you need help? Do you need help? I'm like, no, I think I got this. I had a little sticker by my station and I'm like, okay, that's how I follow. But now, now it's still there in the back of my head because certain products are still kind of numbered in the American system if they're coming from the US. So you kind of get the hang of it.
Right. It is for pediatric teeth. Is it still letters or how's the injury?
Yeah,
I don't even know.
I mean, you could do letters, but it's a different numbering system. So instead of going A all the way to T, it's by quadrants. So it's A to E, A
A
to
and then back.
E. Yeah. Yeah.
I'm like, well, like upper right, and then one, like number 8 is the wisdom tooth on the upper right side.
Exactly.
Okay, so it's A through. I guess that would be. It's
For
not
you
J.
guys, for you, it's A to T. So A to J and then K to T. And
Yeah,
then
but for you guys, yeah,
for us, it's A to E, but you just go by quadrant. So you'll be like first quadrant, A, B, C, D, E.
to E.
But yeah, but the thing is we actually use a numbering system even for pediatrics. So if adult teeth is 1, 2, 3, 4, you keep going 5, 6, 7, 8. So 51, 52, 53, 54, 55. Same thing. So 81, 82, 83, 84. Just go. You continue to count.
Oh, okay, so adult teeth there is like everything 40 and up, and then kids teeth are below 40. Is that what you're saying?
Yeah, exactly. Well, no, it would be above 40. So it'd be like the
Yeah,
51s. Yeah, would be pediatrics. Yeah, exactly.
50s, 60s, 70s, 80s
Yeah.
versus 10s, 20s, 30s, 40s are pediatrics.
Yeah.
Oh, okay. Okay, this is making more sense. Yeah, I was not familiar with.
Yeah, there's the it's like we follow pretty much like the same thing as ortho. So I think ortho does the same thing. Yeah.
Right, right. I do get a lot of like, oh yeah, upper second, upper eights, the upper what would be upper 4s and 5s. I guess would be usually the premolars that we take out from a. Oh,
Exactly.
interesting. Yeah, just to throw it out for listeners, the acronym I like to use for remembering kids' teeth is the most posterior molars are A, J, K, and T. So the acronym is Apple Jacks Kill Teeth because like
Oh yeah,
Apple Jacks is like a sugary. I'm sure you've heard that one.
yeah, I've heard that when I was in the US and I was like, what are you guys talking about? But yeah, I definitely heard it.
I've been using that every day, and yeah, I don't know. It's a cute little one to remember.
Yeah. In terms of, I mean, you asked about the differences between, dental school in the US and Canada. I mean, I think majority of the provinces, the states in Canada follow pretty much the same thing. You know, you're going to 4 years of dental school and you usually do an undergrad. The thing with Quebec, in that state, you have the pre-dentistry option. So what ends up happening is you go like, before you even do the 4 year program, you do 1 year of pre-dentistry and you don't actually have to do an undergrad and then you go straight into 4 years of dental school. So I was lucky enough. I mean, I guess my grades were good enough that I applied for that program and I did 1 year. I didn't do an undergrad, so I don't have a bachelor's degree before dentistry. I just literally did a 1 year pre-dentistry prerequisites only, and you just do those prerequisites, and then you go into you join the 4 year program with everyone else.
Wow, wow, wow,
Yeah,
wow. Wait, so
it's unique to our state.
yeah, I mean that's pretty sweet. Wait, so you did do undergrad or you did do the 1 year?
I did the 1 year.
You went right into it.
Yeah, right into it at
What a
19.
sweet deal.
Yeah.
That's a
Yeah.
great deal. I
I
know
mean,
other.
it's good and
Yeah.
bad because you don't really know if you want to do dentistry. Okay, so the way I see it is like everyone always says they're like, "Oh, you graduated so young. This is amazing." But when I look back, I'm like, I pretty much chose to do dentistry at the age of like 18.
Yeah.
Like when I applied and that's when I interviewed and that's when I started. And from 18 onwards, I do my first year of prerequisites. As of 19, I'm literally in dental school. Is this really the right time to decide your future? I don't know. I think it's a little early. As a 19-year-old, do you really know what you want? You know, the undergrad does help. It gives you a little bit of experience, gives you a little bit of knowledge. So yeah, missed out on
That's
the undergrad life.
yeah. I mean, yeah, you did. It's a pretty good
That's
time.
it.
Ellie
Yeah.
Haladian. Yeah, I saw you. She follows you. I think so. You follow. She's from Montreal. She was saying
Yeah.
for a while, right? And just a quick side note. Do you know? So French, English. Wasn't there one more?
I mean, I know French, I know English, and then I speak a little bit of Spanish just because of high school. I took it in high
Oh,
school.
okay.
But main language is English, French.
Just English, but you
Yeah.
guys need to know both, right? Isn't that like
Yeah, 100%. You need to know like
required?
French to survive. And then initially, yeah, like during high school and elementary school, it's pretty much a requirement. You take the classes, you learn it. It's not like, oh, you enroll into a French school or no, you learn French throughout elementary and high school.
Okay, gotcha. I think that's great. I think it's really important to be bilingual.
Yeah.
Here, I have to be bilingual in English and Spanish,
Yeah. Yeah.
but that's not for work. That's for my fiance.
Oh, okay. Nice. Yeah. I was gonna say for work, and I just feel like in Rochester it's the same thing. You know, there's a lot of Hispanic
A
population.
lot of
So
Spanish-speaking patients, right? Yeah. No, it is extremely helpful. So, did you speak Spanish with them a lot?
I mean, it was a good way to practice because I hadn't taken Spanish since high school. So pretty much all of dental school, I kind of like forgot. If you don't use it, you lose
Yeah.
it. So I kind of forgot. But then getting back into it, even now, I get some patients and I'm like, okay, let me try. I want to try. I really do want to practice Spanish. I actually enjoyed it. I took it for 5 years in high school. So I loved it. Yeah.
It's a great 5 year. Oh, so you
Yeah.
really know Spanish?
I knew it. Yeah, I knew it fluently, But then once I stopped using it, I was kind of like, and now I can understand it, but I got to like pause, think, make my sentences. It's
Yeah.
very similar to French. So sometimes I confuse the two, but yeah,
Hmm. Oh, and then learning dentistry Spanish is another. That's
it's, yeah,
another thing.
yeah. That's pretty much all I want to know right now.
Right? Yeah, every day I actually I think every single one of our assistants are they're bilingual, and so and we have I would say probably like 50% of our patients in the practice I'm at right now are Spanish speaking. So I'm just all day every day we got Bed Bunny going. I'm speaking Spanish. It's but yeah, I'm sure you get it. Not what about in Toronto? How about that?
In Toronto, I mean, yeah, there's a mix. Definitely, like I said, in Montreal, I didn't see Spanish speaking patients. It's just maybe like once in a blue moon. Now in Toronto, like yeah, you see them come by, and obviously they all know English, so like it's fine. It's just sometimes we'll see like they're kind of communicating in Spanish, and then my
Yeah.
anesthesiologist, whenever we're doing GA, we're always like, oh, they're speaking Spanish, and then he's from New York, so he's like, oh, I get to practice my Spanish. I'm like, yeah, me too. And then we'll try, we'll actually talk a little bit, and then when it gets a little serious, we're like, okay, back to English.
Yeah, you're right. You're right. You're
Yeah,
always switching back for the.
yeah, exactly.
I do that too. I would have thought. I guess it's different. Why do we have? So you said Rochester too. I guess like a lot of New York is Spanish speaking people. And I mean a lot of Spanish speaking people. They've been here for years and years, even decades, and know English.
Yeah, still speaking Spanish. Yeah, yeah, no, you're right. Like young parents, and I would be like, oh, they only know Spanish, and I'm like, you would think like someone in their 20s definitely knows English, but yeah, no, I mean, we saw a lot of Spanish, and
Yeah,
we spoke it, we practiced it. A lot of us liked it.
yeah. And I'm surprised not as much in Canada. Not as many.
Yeah, I mean, definitely not as much as the US, but yeah, we do get them occasionally. It just depends the area. I think the population that you're working with, the
Yeah,
suburbs and the cities.
yeah. So tell me about practice. So what days are you working? What are your hours? I'm curious.
Yeah, so I mean, when I first started back in Montreal, I took the academic route. So I was part time in academics and part time in private practice. I was actually a residency director. So I was running the residency program like 3 days a week. Right after specialization, I like went straight into it and didn't know what I was doing. I was like, I don't know how to teach. I don't know how to direct. Forget teach. But yeah, so that was an experience. And I was doing that like 2 days a week. And then the other 3 days a week, I was in private practice. So it was good. It was a good mix of both. And then before moving to Toronto, I kind of like gave it a little thought. I'm like, do I really want to do this for the rest of my life? Like I was under 30. I was like, what's the next move? And then pretty much after that, like after doing that for 4 years, I said, you know what, maybe it's time to go full private practice. And I started looking at my options. And then I came to Toronto with the mindset of working like 4 days in private practice and trying to find something else to do, like whether it's teach at the university again, but wasn't on the top of my list because I wanted to stay away from academics. Not that I didn't like academics, I just felt like I wasn't at that age right now to get fully into academics. And then yeah, so pretty much met a group of clinics. They're pediatric offices. We were 7 offices, and they're like, listen, you can work 3 days in the clinic, and then 2 days you can help us run the offices, since you kind of have that experience of training, mentoring, and
Mm.
you can learn the business. What else do you want to do? And I was like, I want to eventually like partner in. So all those conversations were had, and it seemed like a sweet deal. I was in Montreal, like, kind of just living life. And I'm like, okay, let's just grab my stuff and go to Toronto. So I moved to Toronto, worked 3 days in the office, ended up just running the clinics, like help running the clinics as a manager role for 2 days. And then eventually I bought in. So became partner about 3 years ago. So I'm still doing 3 days a week in the clinic. I started teaching pediatric CE. So that's pretty much
Mm.
been the latest thing. And I do that with my pediatric dentist friend, and we go all across Canada and teach general dentists how to do pediatric dentistry.
Well, hey, so I could get a little quick. How do I do
Yeah.
pediatric? What's your
Yeah.
number one thing? Like, what do you start with? I'm curious now. Yeah,
I
like,
mean, yeah, whenever we teach, like the biggest thing that we get is obviously like pulp therapy and stainless steel crowns. So
hmm
pretty much
hmm
pediatric pulp therapy and stainless steel crowns. Because, obviously they know how to do endo in adult teeth. They know how to do porcelain crowns in adult teeth. But I think the biggest fear, or the least prepared out of dental school, is pediatrics, the field of pediatrics. You're just not confident when you come out of university or dental school as a general dentist. So we definitely teach, stainless steel crowns and pulpotomies are our biggest things, biggest like demand. But behavior management, just interceptive ortho, we'll teach like pretty much every topic. And now the new trend is to do minimally invasive treatments. So kind of, using SDF and fluoride and all that stuff. So we teach that as well. Pretty much anything that you can do on a somewhat cooperative kid, So it's mainly like, we're not trying to get you to do sedations. Like you can send those to us, but the basic patients, we want the GPs to keep them. There's just too many kids for the amount of pediatric dentists.
Right, right. Nitrous, keeping it at
Yeah,
the GP office. Nitrous.
yeah,
Okay,
yeah.
okay. And the
They can do
sedation
that.
is in your way. So most of your patients, you're doing sedation on.
Yeah, a lot of us like because we get referrals, right? And in Canada at least, I don't know how it is in the US, but a lot of GPs want to see kids. They just they'll do the easy stuff and then they'll send away the heavier sedation ones, right? So when we get them, they've already tried nitrous and it's been unsuccessful. So a lot of the times we'll be like, okay, let us try our magic with nitrous. We'll see if we can use our skills and try. But a lot of the times it's like nitrous combined with, Versed. And then sometimes it's general anesthesia, depending on the amount of work, the age of the child. So it's kind of starting to become more, if you go to the pediatric dentist, I would say at least like 75% of them are getting some type of sedation, whether it's nitrous combined with something or
Yeah.
general anesthesia.
Very nice. And then, what are your thoughts on managing the parent as well as the
Yeah.
patient? Do you keep them in the room when you're doing procedures on them, for example?
So I've been around a little bit, in the transition of all that. So when I started, like everyone asks this in our course because they'll be like, "How do we not, keep the parent in the room?" I'm like, honestly, when I first started, I could say it and they would trust me and they would believe me and they would be like, "You know what? Yeah, we'll go sit outside. You tell us what to do." And it was a little bit easier. Now I feel like with reviews online, with legal issues, just things going wrong and I feel like there's a lot of doubt on dentists. And so in that case, I just keep the parent in. Honestly, sometimes it works in my favor when the child is not cooperative and the parent is like, I absolutely want to try with just, local anesthesia. I'll be like, okay, let's try. They'll see that it's unsuccessful. I stop right there and I say, like I recommended, I think that your child needs sedation. And now you got to see it, right? It's not like me coming out of the room and saying, hey, your child didn't cooperate. They'll be like, I don't believe that. Now they have to believe it. They don't have a choice. And sometimes when you get the helicopter parents, that's where you got to set your boundaries. So you have the talk before you even bring them in the room. So I usually have all the talks and boundaries during the consult. And then this way on the day of the treatment, they know where I stand and how involved I want them in this procedure and what our boundaries are.
What are those boundaries that you kind of go over? Yeah, I'm just curious. Yeah, I
Yeah.
need to know this.
Yeah. I always say like verbal is probably the most important thing. So a lot of parents don't realize, when they say things like, hey, don't worry, it's not going to hurt. The child will be like, wait, why are they telling me? Was it supposed to hurt? Like, is something about to happen that might hurt? So, the parent is coming from a good place. And I talk about like the words hurt, the words needle. These are things we don't use in a pediatric office. So don't mention it. We'll find creative ways to, talk about local anesthesia or the jelly or, the rubber dam clamp. And that's one thing. So terminology is super important. And then the other thing is the way I tell parents is like, if you're there and they feel your presence, they're going to know that they have an escape. So if something doesn't go as planned or is not comfortable for them, they always have you as an escape. Whereas if you're distant and you're sitting in the corner and it's for your own comfort and you're watching, then it's fine. They're going to try to push through and try to cooperate to get the procedure done. Now, in some cases, parents do help. I say, listen, I might find you useful. I might need your help, but I'll ask you for it. So I don't want you standing right there because at the end of the day, I need to focus on your child. And if any distractions happen, I can hurt your child.
Right.
So when you make it about the child, it's a lot easier to get them to kind of be on board with your plan.
Yeah. It's so interesting because trying to implement some of these. Yeah, I had a recent thing with like trying nitrous, trying other things, and still uncooperative, yelling, screaming, and it's not safe. It's not safe for you. It's not safe for your assistant. It's not safe for the patient, just like you said. But then what happens when the mom starts to question that and not believe you? Like, no, isn't there something else you can try? And like, I mean, maybe sedation, but with kid sedation, some offices that we have, they're okay with under 13. Other offices, it's 13 and up. And then like how to have that conversation. And then what if I can't do it that day in that office? We don't have, how would you phrase that?
Again, I always make it about the patient. So I say, listen, like if I push any further at this point, I may traumatize your child. I may also injure your child. And I might do inadequate work, right? So the way it's always about the kid at the end of the day. And it's true that it's always like, it doesn't change anything for me if I don't get the filling done today or if I do a bad filling today, right? So my goal is always to make sure I do the best treatment in the cooperation that I have, but also without harm to the child and without traumatization, because it's these appointments, it's these scary, fearful, uncooperative appointments that they remember later on. And that's how we see adults being anxious of the dentist or fearful of the dentist. It's because of that childhood buildup, right? So I always make it about the child, and I always say, hey, look, like, I'm trying to not traumatize your child. I think they've had enough. We may want to start fresh on another day. We may want to choose a different timing for the appointment. Children that are rested in the morning show better results than someone at the end of the day in the afternoon. So things like that, obviously talking about how they think that, a lot of the times parents think like, without general anesthesia, it's safer. And in general, yes, I agree. General anesthesia has risks and it is associated with complications. However, a child who is uncooperative and moving with me having a drill in my hand is also unsafe, right? So I think we forget that there are risks and dangers of a mild sedation, uncooperative child kicking and screaming with us having sharp instruments in our hands. And I think the parents forget that because they're so focused on the sedation part, but not understanding the traumatization and the physical injuries.
Right. And then have you ever gotten pushback from, you went through everything with the parents, you kind of explain like, we can't do this. And then they keep pushing. And when it's like, look, there's only so much I can do. And then they leave a nasty review on your page.
Yeah.
Any tips, any thoughts with that?
Yeah, for sure.
We're working right through this together.
Yeah, I love this question. So what I always say is, as a general dentist, you always have the option of referring. So say it clearly, this is out of my comfort zone. If this was my child, I would not treat them because I'm not going to be able to provide adequate treatment. I'll refer you to a specialist, right? That's how the GP gets out of it. Now, let's say they push. At the end of the day, the way I see it, when I get pushback and parents tell me like, no, I want you to do this and this, I say, listen, at the end of the day, I've studied this, I've been trained in this, and according to my ethical code and as well as professional code, I cannot continue with this treatment. Now, there might be pediatric dentists out there that will do this. I want you to go get a second opinion. If I was you and I was thinking like you, I would go get a second opinion. These parents will leave. And to be honest, they're seeing it as like, oh, okay, he told me to go get a second opinion. It's nothing bad. Like, they're not rejecting me. They're just saying, go get a second opinion. When you're ready to do the treatment like I recommended, come back and we'll gladly do it. And usually the ones that go away and never come back are the ones I don't want coming back, to be honest. And the ones that do come back, they've had the time, they've gotten the second opinion, they've gotten the confirmation, they've done their research, and usually they come back and they happily go through the treatment. So I have no problem gently kind of telling them to get a second opinion. And at the end of the day, as a general dentist, you have even more ease of just kind of saying, this is out of my comfort zone. Like, I've never done it. Just say that. Like, at the end of the day, you just want them to go to the specialist. So it's a lot easier. GPs don't have to do every pediatric case. Pediatric dentist, we have to try it.
Yeah. Because then, like, so in an oral surgery office over here where we get patients like come in saying, yeah, but I was told by my general dentist that you guys do sedations here. You guys can do this. And then it gets to the point like, yeah, we can, but your child needs to cooperate at least to a certain extent for us to get, the IV access or, whatever it may be. Yeah. It's because it can get difficult. And I don't know.
So the question for you, do you guys like ever then refer those patients to the hospital? Like, could they go to a hospital and get treated in things that you guys don't do in a private office?
Yeah, and I do refer to the hospital, but then, the fact of the matter is that hospital visit, just to get the consult, could be 6 months. That's 4 to 6 months right there. And then once they finally get there, that's a consult visit. And then these kids going to have to go to the OR, or they're going to try it. It's going to be a miserable disaster, and it's got to be going to the OR. That's another month to 3 months, or maybe never, because it's 2 baby teeth because the kid didn't want to cooperate in the office. Like, that's the reality behind it. But it's also like, and this is all the way, by the way, for listeners, we're talking about 1 out of like 50 kids that are, and I don't know, or maybe like 20, 25, but like, think about this. Is it, and then I guess a certain level of parenting has to do with it too, because some kids are cooperative and listen, some kids don't. And I think there is a level of parenting involved where it's like the kids learn to listen, and some kids don't want to listen or throw a tantrum. And it's like, maybe another day, maybe, I don't know. So I like that. What are some tricks we could use with kids? Maybe on a fresh day. I like that. A fresh day. That's a good one. Maybe we need to try another day for up in the ante. Say it was like local or nitrous, and now we got to go up to IV sedation. So maybe we try IV sedation. After the IV sedation, how do you put it so like respectfully and so that they understand where it's like, I am going to have to refer you to a hospital to get this done under GA. And I guess that would be the next thing, because no parent wants to do that. They just waited 3 months for this appointment.
I
And
know. And I think that's where like I always tell any of our new dentists that join our offices as well as like teaching, is that have those discussions at the beginning. So I literally run through every scenario at the consult. I say, listen, if they're cooperative, we're going to try this with local anesthesia. The first appointment's going to go well. We're going to try the second appointment. If at any point it doesn't go well, we may have to add sedation. Now, if ever the sedation doesn't go well, or this child becomes uncooperative, or there's more work to be done, then at that point we'll try general anesthesia. So now they've already known like the little timeline and the map of what's going to happen. It's when you catch them by surprise and you're like 3 months in and now you're like, oh, by the way, I can't do this. So I have it clear cut right in the beginning. And then if they decide to stay and go through that process, they're making that decision and they're staying along with it and trying. And at any point it fails, I've already told them that this was a possibility. So there's no surprise. They knew this may happen. It may be one of
I like
these.
that a lot. Yeah. Let's lay out the roadmap at the initial visit, really early on. Like, hey, if this doesn't work on the local, we could always add on nitrous. If the nitrous doesn't work, we have another. That's a really good point. I haven't been doing that. I really need to make sure that parents know that we have backup options. And when you lay it out, like you said in the beginning, it's like, okay, hey, we're going to have to up the ante.
Yeah. And
Have
some of them
you?
I already say, at the consult, I'm like, I would normally do these three options, but because your child is not cooperative, I've already taken out this option out of the picture. And so they know that there were more options, but yes, he's right. My child isn't cooperating. If they can't even take x-rays, I'm not going to try to do it under local anesthesia, right? So I'm going to have to
Yeah.
add nitrous. So just kind of reminding them that, yes, I did consider all options, but this one doesn't fit the criteria.
Yeah. 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 Huh. And then have you ever had, with parent in the room, kids being uncooperative, for our level of doing a procedure, doing surgery, drill in the mouth, needles, sharp instruments, not cooperative? Have you ever had the instance where a parent is like, what do you mean? We could do this. We could do this, right, Jeremy? Jeremy. And Jeremy's not having it. But
Time, all the time.
I mean, like, now, what do you do in that situation? I've had this a couple times now, and I forget what I did, but
Yeah. You have to read the situation. Now, obviously them saying it, if it brings improvements, sure, I'm going to utilize them more then. But if it's not improving, at some point you got to draw the line, which might be based on time. If I've spent 30 minutes trying to just put the jelly on, that's my cutoff.
yeah,
That's my
yeah,
cutoff right there. We've already spent 30 minutes. We haven't even anesthetized, right? Same way as if that treatment is starting to become a little bit dangerous, I'm starting to already think about how do I wrap this up in a temporary way? How do I
yeah.
get this done in a safe way? And I'm starting to bring that road towards there. And then I just tell the parent, I stop right there. I'm like, at this point, it was starting to become unsafe and the quality of the treatment was declining. So I decided to put a temporary filling in there. And now we'll have to figure out, let's sit him up. He'll sit, watch TV. Now let's talk about what our next step is.
Right. I did that. I didn't do like, let's sit them up and let's talk about what our next thing is. But everything else I did almost exactly the same. I got a better review for doing that.
Yeah, honestly, and that's the problem now, right? Like I think the biggest difference is the consult. Like I'll see kids that are super cooperative, but I'll still have that same conversation. I have literally the same spiel, copy and paste, regardless of age and cooperation, because sometimes you just don't know when it's going to fail. Sometimes you think the kid is great, turns out to be terrible, and sometimes
Wait,
the terrible kids turn out to be great, right?
wait,
So
isn't it? It's a shocker.
yeah. Yeah. And you're lucky in one, but in the other situation, you're like, oh, I wasn't planned for this. I never had the conversation. Like even just fillings versus crowns versus extractions, like I'll tell them from the day one, like that filling doesn't look that bad, but I'll say, hey, if it gets worse, it may need a pulp therapy and a crown. And if it fails, it may even need an extraction. And this is because one, we may have to cancel appointments if the child is sick. Now there's a delay, so there are all kinds of things, but that consult was had in, June and now it's October. Those things are possible, but I've already discussed them in June,
Right,
So,
right. Start to lay the seeds out early.
yeah. The
Yeah.
talk is the most important thing, I think. It just sets everything up and it prepares parents. And at the end of the day, you've kind of laid out the options. You tried and they saw that you tried. Whereas if there was no other options and you just tried and stopped, they're going to be like, okay, well, what now? You just gave up.
Yeah. Yeah. No, this has been really helpful. I'll have to
Nice.
come up with some more of the spiels to try it. No,
Yeah.
because and God, when you get a bad review, that just crushes you. Like it crushes you for the day, and you're like, that. A lot of times they're not even true, right? Some of these reviews are just
Majority of the time.
you sound like you're out there with killing people, and you're like, whoa, God, did you hear anything that I said when we discussed like risk benefits, also like what we could do alternatively? And yeah,
Yeah.
it's
Majority of the times they're not true. You don't even recognize the person they're describing because that's not what happened. It's just they're also upset. They wasted their time. Obviously, people are taking time off work. So sometimes it's even that at the end of the day, I'll say, listen, like this child needs 4 appointments. That's a lot of time. You're going to have to take time off work. They're going to take time off school. Let's try the first appointment. If it goes really well, then we'll continue. But if ever it doesn't go well, we have to think about other options. So it's kind of like I just make it about the patient. And usually when I make it about the patient, the parents are like, okay, we're on the same team rather than, I'm the outsider and I'm suggesting something.
right. Yeah. Could be New York too.
It could be, yeah, exactly. It's the areas as well. Yeah, 100%. I go to different clinics, right? So when I go to different clinics, the spiel changes just a little bit from clinic to
So
yeah.
how have you tweaked it a little?
So yeah, I mean, like I didn't see this when I was in Montreal because I used to just work at one clinic. So I went there; it was always the same stuff. But then when I go from area to area, it depends on like the types of people. So there's certain areas, where there's a certain type of population that is involved in like Google research. They went to
Mm,
Google and they come back. So I pretty much have to be on top of my game when I'm talking about, studies show that, or the science behind this. I've been doing this for 12 years. This is my 4,000th crown, this month
yeah.
or this year. So you kind of like have to back yourself up and you have to prove yourself. Whereas then I go to certain areas where I'm like, hey, we need to do a, root canal and a crown. And they'll be like, okay, cool. When are you going to do it? So
Yeah.
you kind of sense that and you learn that with time, obviously, because it's not on day one that you're going to realize that you need to change it, but it is discussion 100%. I think like the discussion is the most important step.
For sure. For sure. And then the more discussion you have, then it comes up in the review that you were condescending. And you're like, wait, I just taught you the entire like
Yeah. It's about, I say the biggest strength of any human being is emotional regulation. So when you're losing your cool, just remember, just regulate those emotions. And
oh yeah, dude, I've never lost my cool. And it's like, we could sit down for another
close.
45. Oh, very, very close. Very close all the time, right? But oh man, yeah, it's I don't know. Obviously you could tell this is a sore spot as of today. It's just been a shocker.
Don't worry.
And
Don't worry.
yeah, it's crazy. Like no matter
Don't
what you
worry.
do,
The good will wash out the negatives.
we'll see. Yeah, I hope so. Yeah. But man, yeah. Oh, what topics didn't we?
Yeah, yeah. I mean, listen, on the thing of negative review, like I wanted to say something about my experience. I didn't have a knock on wood negative review experience, but I had a literally a threat from a parent, right? So this is years ago. Yeah, this is years ago. I was working and the child started crying, and obviously we're doing an extraction. I've anesthetized. I guess the parents was unaware or thought that we don't anesthetize kids. So when he saw me put the needle, he assumed that I was causing pain. And obviously I was pinching the child. That's what I described it as. And the parent said to me straight, right in my face, right next to me, said to me, if you continue to hurt him, I will hurt you. And
Come on,
and I'm like
it's
first year out.
horrible.
I'm first year out. I just specialized as a pediatric dentist, went back to practice. Literally, I think I completed my first year of like private practice. And when I heard that, like you start shaking just a little bit. You're confident that you're doing the right thing, but it hits you hard. And then my assistant's looking at me and she's like, I don't think we should continue. And I was like, yeah, I don't think so either. So I put the instruments down. I got the child up, had the
Yeah.
conversation with any little bit of courage I had left. And obviously, like they left, they started a Facebook, obviously, conversation on the website, but nothing really like towards me. They didn't know my name. It wasn't a negative review, say on Google or anything like that. But
Yeah.
obviously, they described the procedure, and that was like my first and probably most severe experience. It hits you, yeah. It takes a while to bounce back, and obviously, like now you learn from that, right? Like what did you miss? So maybe I skipped the part about using a needle because I assumed this adult who told me they just had an extraction of their wisdom teeth last week would know that a needle is involved. And I skipped that one description, where I said, oh, we're going to use a needle first and then extract the tooth, but I learned
You say that? You tell the kids you're
so
using
now I
needle?
don't. I mean, I don't say needle to the child ever, but if I have to describe the procedure, like if I'm doing an extraction and they're asking me questions about the extraction, is it going to hurt? I always say, no, we're going to numb it first. So I do mention that we're going to numb it first. And if the child is not looking, I always point, we're going to numb it. And I act it out. So they kind of, got the hint that there's going to be something done first. And I usually just I'm well aware of the child. If obviously the child is paying attention, even if they're watching TV, I know they're listening to everything. Sometimes I just step out of the room and I say, oh, I'm just going to talk to mommy outside. It's too loud in here, and then I just go step outside and I tell the mom, like, this is what I'm going to do. I'm going to give the needle first, and then it's going to numb, and we're going to wait, and then we're going to continue. Just because I learned from that one incident, right? So I rather explain more than less.
Always. Yeah. I always have. And I've never had the experience of explaining more work against me. I've never had that before.
Yeah.
With 5 years, I mean, between dental school, between residency, between, practicing the last couple months. Yeah. So it's quite a learning experience. And yeah, I have been finding out that like certain states have certain, I guess, populations, certain groups in the community that are not groups in the community, but like groups of people where there's a different attitude. There's different attitude toward providers, different trust in providers, different expectation in fees. That's another thing.
Yeah.
Expectation of financials. It was 100% covered. And then I guess certain areas, certain states with, there's quick to leave the reviews. I'm finding out, but yeah, so it's a learning experience. It's very interesting.
And honestly, I see so many, like with our now 5 to 7 offices, like we see so many reviews, and I see a lot of doctors like, get a little negative comment here, a little negative comment there. And I try not to let them bring it down. I just say, listen, at the end of the day, you got to learn from this. There might have been something you could do differently. Maybe there was nothing you could do differently. Maybe you did do everything perfectly. It's just a bad situation. A parent that's unhappy for finances, but takes it out on the doctor, hoping that this doctor will now go get the refund, right? So I've seen that as well, right? So
right,
unfortunately, it's a difficult time.
Yeah, it certainly is. It certainly is. I had another dentist who works with kids on, and they were saying how trust in providers and dentists and providers in general just is at an all-time low.
Yeah,
which is kind of scary, and for you especially, right? Both of us who are working with kids all the time. When you're working with kids, it's like you need to have a certain level of trust, but trust from the parent. Like, I'm not here to screw around. I'm here to help your kid. I'm here to help you. Took off work today to do this. I'm here to help your kid. They need this bad tooth out before it comes an infection and they're out there like this in the hospital. We're all here on the same team here. But then, that trust can kind of lead to some, I don't know, a little bit of friction during the appointment.
Yeah, and it's always the same tip. Like, I think, again, when I'm doing my consult, like my focus isn't as much as I would love to focus on the child. Unfortunately, now it's become more of a focus on the parent. Like, have I won the parent now? Because then we can move on to the treatment day. Like, I can't continue this process if I don't gain their trust. So even when like sometimes patients will come in for emergencies, they walk in, there's emotions everywhere, there's a chipped tooth or fractured tooth, mom's crying, like this, that. My goal, like as much as I want to already tend to the child, I'm kind of like, okay, mom, this is what we're going to do. And I'm addressing mom's anxiety before I'm addressing the child, right? Like, it's just because that's what it's become. If you don't have their trust, one is going to make it harder for you. And two is it makes the experience worse for the child because they're feeding off of their parent.
Right. They're always feeding. There's that energy connection with the parent to the child. I feel like a lot of the anxiety of these kids that come in the office, they've never been to the dentist before. No. Why are you so anxious? And so they don't know what to expect. I think it's coming off the parents, which
100%.
Of course it makes sense, right?
100%. And that's one of the conversations I have. Like usually when I do my general anesthesia days, the night before I call the parents. And the only reason why I started doing that now is because I've seen a lot of anxiety with parents coming in. And now the kid is like anxious as soon as we get there. And that makes it more difficult to put them under. So I'm like, you know what, let me make that 2-minute call the night before, relieve some anxiety. I just made a call before we got on this. And the mom was like, oh my God, I was so anxious. Thank you for calling. Now I feel much better. I'm like, okay, you know what? This will make 100% it way more smoother than had she not had this call. So it's just, maybe it's the unknown. Maybe it's their past experiences themselves. Like they've had horrible experiences. And then it's the idea that it's their child and parenting has changed, to be honest. It's not the same.
Right. It is not the same. It's definitely changed. That's a great idea. I like that. Calling for those, especially the sedation procedures the night before. Yeah. Wow, that is a huge tip because I like to call the bigger case of the day.
Yes.
At the end of the day, call, hey, just how you're feeling. Are there any other questions I can answer? But calling the patients the next day, like, hey, any questions you need going into tomorrow, you're nervous or whatever, that's fine. That's normal. I just wanted to touch base now to hedge that a little bit. I love that.
Yeah. I think I pick and choose. Like, obviously, some cases I'm like, I saw the consult, I remember the consult, and I'm like, you know what? They were so on board. I'm good with this. I don't need to call this. And then the ones that I'm like, ooh, they're having a lot of extractions. let me call them and let me just make sure they're at ease, before we get started.
In fact, I'm going to write that down really quickly. I like that a lot, man. Yeah.
It does help. Yeah, 100%. It takes a few minutes. Let's say I have 6 cases where I'm done in 30 minutes. I do, 6 calls and it's quick conversations, and I have my little spiel, my script ready to go, and it's pretty easy.
That is huge. Yeah, man. Dude, thanks for coming on. What do we hit on everything? I know we're winding down towards the
You
hour
have
here.
anything else you'd like me to talk about? I mean, listen, for me, it's always been about, putting content out to help general dentists. I feel like pediatrics is, like I said, one of the fields that we're the least prepared when we come out of dental school. So my goal has always just been to serve as an aid and an assist, I call it. If ever they need anything from me in terms of pediatric dentistry, whether it's in the US, whether it's in the Canada, I'm down to help. Yeah.
Thank you for that. And you just helped me out a ton on this chat, and
Perfect.
yeah, other people are going to be listening to this. And now we know that we have a safe place we can go and get advice, because treating kids, it can be very, very, very difficult. It can be nerve-wracking. You don't want to hurt a kid. No one wants to hurt a kid. And then here's another thing. When you get, the first time you treat a kid and they scream, a lot of the kids are going to yell and scream just because they don't know what to expect. And then there's the pinch. What do you do in that situation? So yeah, and where do you go? Just like you said, many dental schools aren't preparing dentists or dental students enough for the pediatric space of this healthcare niche. And so I appreciate you taking the time, and everyone that listens to this. This is going to be great. This is going to be great for making that connection to you. And yeah, thanks for the tips today.
Of course, anytime.
Yeah, man. So I'll get this posted up hopefully by the end of the weekend. I gotta see how this episode, the processing. But yeah, everything's good, man.
Thank you, man. Thank you for having me, and you're doing a good job, man. Keep it up.
Oh, thank you. Likewise. Yeah. Hey, when I hit end here, if you could just hang on for 10 seconds, it uploads in those final seconds. I don't know if you've done Riverside.
I've done it before. Yeah.
Okay, sweet.
Awesome.
All right.
Thank
Dr.
you so
Sharma,
much.
Dr. Little Smiles.
Yes, there you go. Yes.
I had to make sure I mentioned. I forgot to mention that in the beginning.
All good.
All right, man. Thank you. Thanks
you,
again.
man.
You have a good night.
Take care. We'll see you soon. Bye.
All right.